Hi everyone, this is Stacia. We're just going to go over chapter 29, physical activity and immobility, and kind of the effects that it has on the body. I have some concepts here for you that you can look through um, at your leisure. So with mobility, very simply put, it's just the body moving. Immobility is the lack thereof. So fitness or physical fitness is the ability to carry out activities of daily living, with vigor and being alert without undue fatigue and with enough energy um, for leisure pursuits and to respond to emergencies. Physical activity is body movement produced by the contraction of skeletal muscles that increases energy expenditure above a baseline level. And exercise, which is good for all of us, is a subconcept of physical activity. It's a planned, structured, repetitive, and purposeful routine for improving or maintaining physical fitness, performance, or health. So activity and exercise require body movement or mobility. Mobility depends on the successful interaction among the skeleton, the muscles, and the nervous system. The skeletal system consists of your bones, joints, cartilage, ligaments, tendons, and then you have your muscles and then your motor nervous system. On page 844 of your book, body mechanics is a term used to describe the way we move our bodies. It includes 4 components: body alignment, balance, coordination, and joint mobility. So your body alignment, that's like posture. So you should have good posture. This contributes to normal functioning and well-being. Check out self-care box on page 845. And that'll give you tips to maintain proper posture. And then your balance, see figure 29.4 on page 845. This is really important for lifting. Coordination, the coordination between the nervous system and the musculoskeletal system. And then joint mobility allows body to sit, stand, bend, and walk. Range of motion is the maximum movement possible at the joint. It can be active or passive. And then you can see pages 846 to 851 for examples of range of motion. Looking at this figure 29.4, you'll see this on page 845 in your F.A. Davis book. Right here, this is more stable for balance here, where they have a wide stance. Here's your center of gravity in a human being right here, about upper pelvis here, right here at the pelvis. That's your center of gravity. And if you're less stable, if you're more narrow, like he is right now. The body achieves balance when it is in alignment. For your body to be balanced, your line of gravity must pass through your center of gravity, and your center of gravity must be close to your base of support. The line of gravity is an imaginary vertical line drawn from the top of the head through the center of gravity. The center of gravity is the point around which mass is distributed. In the human body, the center of gravity is below the umbilicus at the top of the pelvis. The base of support is what holds the body up. The feet provide the base of support. So you're in nursing school and you have an entire career in front of you and you are a valuable resource, but you have to take care of your body to save yourself the burden of disability and also to be able to help patients because you'll be turning them, moving them, putting them in and out of bed, things like that. So take care of your back. So remember, body mechanics involve good body alignment, erect posture, and a wide base of support. To prevent back injuries, we should carry objects close to the trunk. Don't bend over and lift, instead squat down and then lift. Never ever bend from the waist and then twist. Always stand in front of what you're lifting and squat down using your leg muscles instead of your back muscles. You want to keep objects close when lifting, raise the beds to a working height for yourself. Just make sure you always do your final safety checks and you know that the bed is put back down. Push versus lifting, and always get help if you need it. So we're going to test your knowledge with this question. To maintain proper posture, it is important to A, sleep on the softest mattress possible. B, avoid arching shoulders forward when sitting. C, keep your knees locked when standing upright. Or D, keep your stomach muscles relaxed to prevent spasms. What do you think? The correct answer is B. Arching shoulders forward when sitting alters the curvature of the spine and contributes to poor body alignment. So joint mobility is necessary for all activities. You have range of motion, or ROM, maximum movement possible at the joint. You have assisted range of motion when the client is able to move their own joints without any assistance, or passive range of motion where the nurse moves the joints through their range of motion when the client is unable to do so themselves. This prevents joint contractures, increases joint mobility. Like examples could be stroke patients are taught passive range of motion exercises for their affected side, but if the patient is too weak or quadriplegic, etc., then the nurse is responsible for performing their passive range of motion. In the picture on the slide, right here, this picture that you're looking at, what range of motion do you think the nurse is doing right now? Is this active, passive, or assisted? What do you think? You can see more examples on pages 846 to 851 for examples of range of motion. The nurse here is doing passive range of motion. Here are some different types of exercises. You have your isometric exercise. This involves muscle contraction without motion. These exercises are usually performed against an immovable surface or object. For example, pressing the hand against, one hand against a wall. Each position is held for 6 to 8 seconds and repeated 5 to 10 times. Isometric training is effective for developing total strength of a muscle or groups of muscles. It requires no special equipment and there's little chance of injury. Patients who are bedbound can use isometric exercises to maintain or regain muscle strength. Your isotonic exercise involves movement of the joint during the muscle contraction. A classic example of an isotonic exercise is weight training with free weights. As the weight is moved throughout the range of motion, the muscle shortens and lengthens. Calisthenics such as pull-ups, push-ups, and planks, all of which use body weight as the resistance force, are also isotonic exercises. Your isokinetic exercise is performed with specialized apparatuses that provide variable resistance to movement. Isokinetic exercise combines the best features of both isometrics and weight training by providing resistance at a constant speed while the muscle moves through the full range of motion. Machines available at health clubs and physical therapy departments are used for this form of exercise. Aerobic exercise occurs when the amount of oxygen taken into the body meets or exceeds the amount of oxygen required to perform the activity. Aerobic exercise uses large muscle groups, can be maintained continuously, and is rhythmic in nature. It increases the heart and respiratory rates, thereby providing exercise for the cardiovascular system, while simultaneously exercising the skeletal muscles. Jogging, brisk walking, and cycling are common forms of aerobic exercise. Anaerobic exercise occurs when the amount of oxygen taken into the body does not meet the amount of oxygen required to perform the activity. Therefore, the muscles must obtain energy from metabolic pathways that do not use oxygen. Rapid, intense exercises such as lifting heavy objects and sprinting are examples of anaerobic exercises. So, benefits of exercise. On page 855, box 29.3, basically, if you look at that, basically exercise produces exceptional benefits to all the body systems. The self-care teaching older adults about activity and exercise on page 857 would be something that you would want to look at. So what kind of physical activities should I do? To the older adult, we'd say get at least 30 minutes of endurance activity almost every day. Exercise that makes you breathe hard, build strength, and staying power. Incorporate resistance into your exercise. Use resistance training with weights or isometric activity to build strength. Remember that you can do more and are less likely to fall when your muscles are strong. Do things to work on your balance, like standing on one foot. This can help to prevent falls by managing your balance. Daily stretching will help you be more flexible and prevent injury. When should I talk to my doctor? Almost anyone can do some type of physical activity, but before starting a new exercise program, check with your healthcare provider if you experience any of the following. Any change in your health in the past 6 months, shortness of breath or dizziness, chest pain or pressure, or fluttering heart, joint pain or swelling, unexplained weight loss, an infection with fever, eye problems, blood clots, hernia, recent hip surgery, or joint injury. As you can see, benefits of exercise, it does improve your cardiovascular health. It increases muscle tone and flexibility, enhances the immune system, promotes weight loss, and decreases stress, increases overall feeling of well-being. When they say exercise helps release endorphins, it's true. So here's the slide. This is what your self-care teaching older adults looks like in your book. We just went over that, but just remember that older adults unable to perform 150 minutes of moderate intensity aerobic activity per week should be as physically active as conditions allow. Physical activity for older adults should include exercises that maintain or improve endurance, balance, tone, flexibility, and muscle strength. Telling older patients to get up and walk during commercials when watching TV is one way to get them to get some exercise. Sometimes you just, take as much as you can get. So if they maybe live alone or the family only checks in a few times a day, and most of the time they can get up to maybe walk to the kitchen to microwave themselves a meal. They're able to walk to the bathroom. So you would encourage them, if they sit, in their little chair in the living room and they're always watching their programs, encourage them then, if they can't go do a lot of endurance exercise and things like that, you could always just say, during every commercial, go ahead and get up and walk to, the kitchen or to the bathroom or wherever they typically walk, and they can get some steps in that way. So a well-rounded fitness program focuses on flexibility training, resistance training, and aerobic conditioning. The mode of exercise is the type of activity. Aerobic or endurance and muscle strengthening, resistance, physical activities both promote better health. Flexibility training is stretching before exercise because it helps warm up the muscles and prevents injury during exercise. How many times do we maybe, you haven't mowed the lawn for the whole Christmas season and winter season, and then when you go to mow the lawn, you're pushing this lawnmower a certain way, you're walking a certain way and everything, and the next day you might be a little sore because you haven't used those, muscles since doing that activity in the summer the year before. And if you don't stretch and kind of prepare yourself for it, you can have some soreness from that. And then resistance training, movement against resistance increases muscular strength and endurance. Perhaps the most common type of resistance training is weightlifting. Exercising for strength, increase the amount of resistance with each exercise. So you would lift more weights, right? Exercising for endurance, increase the number of repetitions with each exercise. Aerobic conditioning, fitness and body composition are improved by aerobic conditioning. Components of aerobic conditioning include intensity, duration, frequency, and mode. Intensity is how hard one is exercising. And then amount of physical activity, duration is the amount of time that one is exercising. Frequency indicates how often one is exercising. In your book, if you check out the Department of Health Physical Activity Guidelines for Americans, that's on page 852, page 29.1. So here are some other benefits of exercise. Regular exercise or other physical activity produces long-term health benefits, including a lower risk for early death, heart disease, stroke, type 2 diabetes, hypertension, hyperlipidemia, metabolic syndrome, colon and breast cancers, and depression. People with disabilities also benefit from physical activity. For older adults, walking is a good form of exercise, and the risk of injury to joints is lower than physical activities. Brisk walking for as little as 30 minutes a day, when done consistently, promotes weight loss and maintenance of normal weight, lowers the risk of disability, reduces loss of bone density, and promotes better heart and lung function and muscular fitness. Moderate intensity walking helps to improve strength, balance, and muscle tone, all of which help to prevent falls and to improve overall physical stamina. It enhances psychological well-being, reduces depressive symptoms, and improves memory and mental clarity in the older adult. Risks, of course, there are risks. Cardiac injury, fear of triggering a cardiac event deters some people from exercising. However, physical activity is rarely life-threatening, especially when compared with the health risks related to sedentary lifestyle and a low level of fitness. Musculoskeletal injury, high-impact exercise may pose a risk for injury to bones, joints, and muscles. However, you can prevent most such injuries by ensuring proper body alignment, as well as gradually increasing the activity level or varying activities. Weightlifting using correct form and appropriate weights markedly reduces the risk for injury. Dehydration, fluid and electrolyte loss occurs with prolonged exercise, high ambient temperature, certain meds, and underlying health problems. Keep in mind that water is the best choice during and after most exercise. Some sports drinks contain glucose and electrolyte replacement for endurance activities or vigorous activity. And then temperature regulation problems. Hyperthermia can occur when the person exercises in a hot climate. Hyperthermia is often accompanied by dehydration. Heat exhaustion is a potentially life-threatening event. Signs of heat exhaustion include lightheadedness, nausea, headache, fatigue, hyperventilation, loss of concentration, abdominal cramps, elevated temp, and cold, clammy skin. Hypothermia can occur when the person does not wear proper clothing or is exposed to cool water for an extended time. It is characterized by fatigue, confusion, and lack of coordination. We'd want to consider too if people were on an exercise plan, just as an aside, and you know that they're, heavy duty joggers or they exercise quite a bit, but they may be on medication that could affect their loss, when they're losing those electrolytes. Sometimes they're losing valuable electrolytes, right? Like sodium and things like that. So you'd want to properly educate them on the medications they're taking if that could lead to some form of toxicity from a med. And you'll learn more about medications like that when you have your little mental health section in whatever class you're going to have that in. So what factors affect mobility and activity? Well, I'm glad you asked, because on page 856, it will tell you some factors that affect that. Developmental stage. So as expected, older adults are the least active age group, but they are also the age group most likely to participate in fitness activities rather than sporting or outdoor activities. Nutrition. Obesity often leads to chronic health problems, which further reduce activity and contribute to further obesity. Some chronic diseases can lead to issues with muscle wasting and fatigue. Lifestyle, personal values about exercise and fitness. So you have some patients that are just like, I love to do it. I get up at 4 o'clock every morning and I go for a jog. And then there's just some people that's like, dude, I'm not going to do it because I'm too lazy, right? So some people love it and some people don't. So when you base your plan of care on people, you have to take that into account. What do they believe? How much do they value it? So if somebody is just like, God, it's just such a chore, then you could, start low and slow. Just be like, okay, we'll just start out by just walking to the kitchen during commercials. And then, you could up the game a couple weeks later by reviewing your care plan and saying, okay, would you want to maybe invest in like a little foot bike? So while you're sitting in your chair, you could use that little foot bike that, imitates a bicycle while you're watching your program, and you can kind of reevaluate your care plan every time to see if you can get them to step up a little bit on their fitness. Cultural beliefs also influence exercise. So, when you think about some cultures, maybe they won't go to a gym because it's got men and women, and, maybe they can't wear certain clothing in front of men, or, maybe men don't want to be around women. So sometimes cultural beliefs do affect how people will engage in different exercise programs. And then obviously environmental factors. So obviously if it's really raining out and stuff like that, maybe they can't go out for their walk. Maybe it's really, they live in a highly polluted area. Maybe their neighborhood has more crime than, say, the park 30 miles away, but maybe they don't have the finances to get there every day. And then a support system. Sometimes if you have good family support, you got a buddy system going, exercise exercise programs might work better. So there are some problems that affect bone integrity. On page 858 to 859, when we talk about osteoporosis, for example, it's where there's a decrease in total bone density. After age 30, bone loss begins, and women experience a rapid decline in bone mass at menopause. This can increase the risk of fracture with even normal activities, and a sedentary lifestyle increases that risk. Female individuals experience a rapid decline in bone mass at menopause, and male individuals, a gradual loss continues. As bones become porous, they become weak, leading to vertebral collapse or fractures of the long bones of the arms and legs. Fractures may occur spontaneously or with slight trauma. The best thing you can do to help with bone density is weight-bearing exercises. So walking actually does help with that. Genetics, maybe there are other factors that affect it. Their genetics, chronic disease, and lifestyle choices also play a role. The most common risk factors for osteoporotic fracture are advanced age, low bone mineral density, and previous fractures as an adult. Smoking, low calcium and vitamin D intake, excess alcohol use, and sedentary lifestyle also increases this risk. So we talked about sometimes if they have osteoporosis, they may get a fracture easily. A fracture is a break in the bone. So signs and symptoms of a fracture include tenderness at the site, loss of function, deformity of the area, a line of bruising along the fracture, and swelling of the surrounding tissues. However, they always get an x-ray, and that's how they get a definitive diagnosis. Fractures are classified according to the type of damage. The type and severity of the fracture determine whether casting, traction, or surgical repair is necessary. To learn about caring for a cast at the home, refer to the home care box, Teaching Care of a Cast at Home in your book. Here is just a little picture of some fractures there on that arm. A compound fracture is, a compound just means it's open. Broken bones seen through the skin, typically caused by trauma, accidents. Most likely they'll need surgery for that, and then they may wear a cast to immobilize it. Green stick, that's something strong enough, something bends the bone enough, to crack it, but not to break it into. If you kind of think of a green stick fracture, just, how you get like a twig, but maybe you get one that's not real dry or anything, and you can they won't break, but they kind of twist and splinter. That's kind of what that bone looks like. Kids are typically affected with these breaks. And then you comminuted fractures. They're broken in at least 2 or more places, typically caused by car accidents or falls from a high place. Probably need surgery for that. And then simple or a closed fracture, it does not protrude through the skin. So immobility considerations. Immobility can cause atrophy. Atrophy is just a decrease in the size of the muscle tissue resulting from a lack of use or loss of innervation. Stiff joints and contractures. A contracture is a permanent shortening of tightening of the muscle fibers that reduces flexibility and makes movement difficult. Pneumonia from immobility, so where it says decreased lung expansion, they're not breathing deep. So that's not good. No movement. So when you have no movement, the blood pools and it's not flowing right. So that puts them at risk for a blood clot. Constipation. Protecting the immobile patient's skin integrity is important. So they have to be turned every 2 hours to promote blood flow to the skin. And then providing passive range of motion for people who can't control their limbs themselves. Quadriplegics prevents contractures and promotes joint mobility. Active range of motion for those who can control some. And then we should always encourage the patient to do as much as they can on their own to promote independence and function. And just remember, we always tell patients, because this is really 100% true, that if you don't use it, you lose it. And that's true. And then you could look on page 861, see what, go through that and see what prolonged immobility considerations there are. So for your assessment, we do a focused nursing history and focused physical assessment. So your nursing history, you would want to focus on activity and exercise. What do they normally do? What is your usual activity? What's your fitness goals? What do you want to get to? Do they have any mobility problems? Do they have any underlying health problems? What's their lifestyle like? and external factors. Your focus physical assessments, it's important data to include in a physical assessment related to activity and exercise, include their vital signs, their height, weight, body mass index, body alignment, joint function, gait, muscle strength, and activity tolerance. So your subjective and objective data with this. So subjective, the patient complains of pain or discomfort with movement and exertional dyspnea. You might not be able to see that. Now, if they were really short of breath, that would be objective because you could see that. Objective, limited range of motion, limitations in fine or gross motor movement, poor coordination with movement, difficulty turning, unstable gait, decreased reaction time, postural instability, slowed movement, and difficulty performing activities of daily living. You would see some of these when you do your, in your 109, when you're doing your head-to-toe assessment, you'll be checking some of these things to see how they walk, what their gait's like, what their balance is, things like that. So your analysis or nursing diagnosis that specifically describe activity and exercise problems include activity intolerance. It's a state in which a patient has insufficient physical or psychological energy to carry out daily activities. Impaired physical mobility is the limitation of independent purposeful movement of the body. Risk for disuse syndrome exists when a patient's prescribed or unavoidable inactivity creates the risk for deterioration of other body systems, or a sedentary lifestyle is a habit of life that is characterized by low physical activity. Planning outcomes or evaluation, nursing outcomes classification, standardized outcomes for mobility diagnosis focus on energy maintenance as well as mobility. Individualized goals and outcome statements depend on the nursing diagnosis used. Because activity and exercise abilities are individualized goals, we must consider the patient's current condition, expected condition changes, lifestyle, and values. You can't really make a care plan for a patient without their input because you have to know what they think about it. We can make all our, care plans look really pretty with our nursing interventions, but if the patient doesn't believe in them and doesn't think they'll help them, then it's not going to work. Here's a couple of examples of goals for your planning or evaluation. So, when you put them into place, you want what your goal is. You want it to be measurable. So, my goal is in a week, he'll independently transfer to the wheelchair by this date, or we'll discuss his feelings about his activity restrictions by this date. And then you would review that again on that date to see what needs to be changed again. That's why your clinical judgment model and your nursing process is just repetitive because you're making it, then you're always evaluating it, and then you're reevaluating it, and you're making it all over again. And that's how the nursing process works. So we're going to test your knowledge of the following interventions for the client who's immobile. The nurse will give priority to A, encouraging a diet high in fiber and extra fluids. B, administering the PRN medication for sleep. C, having the client use the incentive spirometer Q2 hours, or massaging the client's legs every hour. What do you think? If you chose C, you are correct. Use of the incentive spirometer helps to prevent atelectasis, which improves oxygenation, a priority need. Remember that immobility causes them to have decreased lung expansion when they're breathing. So how do we promote exercise in clients? So we try to plan and vary exercise routines, use the buddy system and then a reward system, integrate exercise into routine activities like we talked about where the people watch their TV and get up for commercials or things like that. Attain target heart rate, so they're counting their pulse and everything as they're exercising. You see a lot of people do that at the gyms. And then collaborate with dietary or nutritionists for healthy food choices. They can have therapy, physical or occupational as needed. They may need a wound specialist if immobility has led to open areas. And just remember that nurses are the examples for our clients. And what example are you giving? So when you're positioning patients and things like that, nurses need to protect your backs. right? So when you're positioning patients, proper alignment of hospital bed. So you want the bed up to where you're doing it, and you want them to be properly aligned in the hospital bed. Use of range of motion, incorporation of pillows, wedges, side rails, overhead trapeze. This will help them pull themselves up in bed. Footboards, sandbags, trochanter rolls, splints. You can use all kinds of things to get them nicely aligned in their bed. So common patient positions. So the Fowler's positions is typically with the head and torso raised 45 to 60 degrees. And semi-Fowler's is with head and torso raised about 15 to 45 degrees. You have your lateral side lying, your prone lying on their stomach, your semi-prone position where the lower arm is positioned behind the patient and the upper arm is flexed. Supine, flat on back, also known as dorsal recumbent. FYI, patients who are short of breath or obese can very rarely tolerate anything other than semi or Fowler's position due to lung disease or adipose tissue. And of course, when your patient has trouble breathing, as long as it's not contraindicated, sometimes if they have a brain injury and they got swelling and things like that, you have to consider all that. But, if you have a COPD that they're on oxygen and someone left them in their bed too low, your first instinct would be to put their head up a little higher so they can breathe a little bit better. So when we're moving a patient up in bed, frail patients slide down in bed because of gravity and their inability to correct their position. Elevating the head of the bed accentuates the slide and places a patient in an awkward position. If the patient is light in weight or able to assist, you will be able to move her independently. Turning a patient in bed is the most important intervention to protect a patient's skin and prevent other complications of immobility. For efficient use of time, try to time turning to coincide with moving the patient up in bed. Pillows and other positioning devices help the patient maintain the new position. Log rolling is a special turning technique used when the patient's spine must be kept in straight alignment. Log rolling moves the patient's body as a unit. Page 874, moving a patient out of bed, transfer bed, like with the gait belt. Most hospital units require its use, or one belt per patient. And if the patient likes, in some places, especially long-term care, some patients prefer to wear that gait belt all day long. And if they prefer that, then you would just care plan it so that, if state came in, you would say, well, we're not going against her dignity. She prefers to do that. So you could do that. Physical conditioning. Patients who have been confined to bed for more than a week or who have sustained major injury require conditioning before they are able to resume walking. Conditioning exercises include quadriceps and gluteal drills. The quadriceps muscle group and the gluteal muscles are the largest muscles of the body. Patients who are confined to bed can perform isometric exercises to prepare them for walking. Arm exercises. Patients use the biceps and triceps muscles when getting out of bed and for crutch walking. Be mindful of any cardiac or musculoskeletal precautions that restrict arm movement, weight bearing on the other hands and wrists, or other body injury. If lymphedema is present in the upper extremities, do not encourage arm exercises or use the trapeze unless directed by the primary care provider. Dangling, using this position to prepare the patient to get up in a chair, stand, or ambulate. Patients who have been confined to bed frequently become lightheaded or develop orthostatic hypotension when first getting up. Dangling allows the patient to experience being upright with limited risk of falling. Assistive devices patients use, they use canes, walkers, braces, crutches. And then, of course, we do have much more to help transfer people, not just by using a gait belt. They have transfer boards, and some patients can actually be trained to use the transfer boards on their own. Mechanical lifts, those are always quite nifty, and then a transfer belt that we talked about. I'm hoping once I save, oh, there it is. Okay, good. So this is an actual video that you'll need to watch when you're reviewing this PowerPoint, so I'll let you do that. But we'll talk about assist devices like their cane, walker, braces, and crutches. Canes are ideal for the patient who needs minimal support and can negotiate stairs. Hold the cane on the stronger side of the body. Distribute weight evenly between feet and cane. Advance the cane and the weaker leg at the same time. Then bring the stronger leg through, avoiding leaning over on the cane. Maintain the rubber tip integrity for traction. Walkers provide a wide base of support for ambulation. Stand between the back legs of the walker and not too far behind. Pick up the walker and advance it as you step ahead. If one leg is weaker, move it forward as the walker moves forward. Pick up rather than slide the walker. Crutches, that's on page 878. Tripod position is the basic crutch gait standing position. Place the crutches 6 inches in front of the feet with the crutch point 6 inches from the patient's center. In this position, a triangle is formed by the crutches and the body. 5 crutch gaits exist: 2-point gait, 3-point gait, 4-point gait, swing to gait, and swing through gait. See, there's a chart in your book to review. FYI, if you're ambulating your patient and they begin to fall, what do you think you should do? Well, what do you think? If a patient is getting ready to fall, you would yell for help and hope somebody's around. You would protect the client's head as they go down, guide the client's body down to the ground, and wait for assistance to get them back up. And just remember that that is still considered a fall, and an incident still would be completed, but it could be an assisted fall where you tried to protect them and prevent any injuries during the fall. And don't forget to watch this video. Okay? All right, we're going to test your knowledge again. Identify the true statement about devices used when assisting clients to ambulate. A, the client should stand a foot back from the back legs of a walker. B, a cane should be used by the client to support the weakest side of the body. C, a transfer belt should be placed around the client's chest for maximum lift. Or D, each crutch walking gait begins with the client in the tripod position. What do you think? Correct answer is D. The tripod position is the basic crutch standing position from which the client then moves forward. This right here is incorrect. Those page numbers are not right, so do not pay attention to this. There is crutch walking in your chapter for this PowerPoint, so look for that, but ignore these page numbers, okay? And just remember, I want to let you know that crutch walking, sometimes you will see that on your NCLEX exam, and you may see that on exams in this class, okay?